So when you've got these patients, we give them a lot of drugs which are generally targeted at preventing infections or complications. And I'm going to talk about a few of them right now. So in terms of antiviral therapy, we really are concerned about varicella zoster and herpes simplex reactivation or actual initial infection in all of our patients on any chemotherapy, whether they be stem cell transplant or other non-transplant chemotherapy regimens. So for that, we put almost everyone on famciclovir or valacyclovir, or in some cases where they can't take oral, we'll use a lower dose of acyclovir intravenously. Pretty much everyone is at risk if you're on chemotherapy or have that disease. Then we think about pneumocystis jirovecii pneumonitis, or PJP. Not everyone needs this, so those that have an allogeneic stem cell transplant definitely need it. Those with acute leukemias need it, particularly ALL. Those that have high intensity chemotherapy, or those that are on greater than 20 milligrams of prednisolone for more than a month. They're the high risk population, and we generally use trimethoprim sulfamethoxazole, also called Bactrim or Resprim as the brand name, because it's so much easier than saying trimethoprim sulfamethoxazole. You can use dapsone, but there's a large cross-reactivity, and the main reason we don't use Bactrim is either for bone marrow suppression or rash. So if it's rash, we don't use dapsone. And so our main second go-to is pentamidine, because it doesn't have the bone marrow suppression effects, and it doesn't have the same rash that some people have with Bactrim rash. However, pentamidine is not as effective a anti-PJP treatment. Then we have anti-tumor lysis syndrome, so those that have high-grade tumors, so very aggressive like DLBCL, or very high amounts of tissue, disease burden, ALL being one of them as well, or those that are having high-intensity therapy, will generally have anti-tumor lysis treatment for at least the first cycle of their chemotherapy, because as all of those cells die off in response to the treatment, they release urea, urate, and other byproducts of cellular death. So we vigorously hydrate some of these, and almost everybody is on a decent dose, typically 300 milligrams of allopurinol for at least the first round of chemotherapy before we drop that off. In severe cases, we use a direct inhibitor of the urate enzyme, which is rasburicase, and we don't usually continue the allopurinol at the same time, and that usually one dose will cover for a few days. Antifungals are a little bit tricky, and they require risk stratification in terms of which chemotherapy we're on. If you're dealing with transplant patients, it's pretty simple. They're all in the high risk category and they all get the best possible treatment. So really the options are whether you have no prophylaxis, or if you've got a low risk, we use anti-candida prophylaxis. And if you're in high risk, which is generally your acute leukemias and transplant, we use mold active prophylaxis. So that's going to cover mold and yeast fungi. So to understand that, we need to take a step back and understand, in terms of humans, which of the fungi families that can affect immunosuppressed patients. And that's such the case with allogeneic stem cell transplant patients. I think broadly it's helpful to think of them as yeasts and molds, and there's a couple of other related categories, but they're the two big ones. Yeasts generally are candida. There's a vast range of them, and the particular ones within there that you need to think about are Crucii and glabrata, because they're resistant to fluconazole. The others will respond really well to fluconazole. And then Cryptococcus is the other common yeast, and that comes in neoformans, which is usually associated with HIV and immunosuppression, or Cryptococcus gattii, which is non-HIV related. Within molds, it's helpful to think of aspergillus or aspergillosis being the infection as aspergillus, typically in the lungs, and then other non-aspergillus infections, mold infections such as scedosporum or fusarium. These are generally, if they get in, they can't really affect immunocompetent hosts, but if they can get into immunocompromised hosts, they can be very difficult to clear, even with appropriate therapy. So you can see here, I've chosen a few of the common kind of antifungal therapies, and I've chosen to list them compared to Candida, Candida glabrata crucii, Cryptococcus, Aspergillus, Scedosporum, Mucor, and Histoplasma. And you can see that fluconazole has a very limited utility outside of Candida that's not glabrata and crucii, whilst Anadula extends the spectrum across most of the fungi and has some limited aspergillosis effect. Posaconazole, which you'll see as our standard use in Australia, which is mold active prophylaxis, has great yeast activity and great mold activity at the same time, and can be used as treatment level doses. And we sometimes switch to voriconazole for specific molds where it has better activity, and we measure the levels. Some cases will actually escalate to ambisome, which is liposomal amphotericin B. It's intravenous only, and we can use that when we're dealing with very complex molds. So I think of the azoles, think of like, I think this is Danny DeVito and Arnold Schwarzenegger. Posaconazole just does not compare to fluconazole. Posaconazole is just better in every single way. Fluconazole has very limited utility. Sorry, Danny DeVito. So when we're dealing with a high-risk group, we use posaconazole. It's a more expensive drug. And sometimes when we can't use that, we might use amphotericin B IV or rarely voriconazole. The low-risk group, we use fluconazole, and if you can't use that, we might use itraconazole or anadolafungin. What are these drugs that you're not maybe as used to, and what are the things that we need to think about? So let's talk about posaconazole first. Actually, of all the azoles, it has the least P450 inhibition issues, which is great, and it can cause hepatotoxicity, but it's usually not too bad. But the issue is it has the least absorption of all of the other azoles. So posaconazole, when they have diarrhea or bowel edema, often doesn't get absorbed, and we need to switch to IV or an alternative agent. We generally measure trough levels twice a week to make sure that they're getting the right amount and not too much posaconazole. And in renal failure, the solvent that the posaconazole is carried by accumulates if the GFR is less than 50, and that may then alter concentrations. And if you're in hepatic failure, which is the main clearance, it may double the half-life. And again, measuring the level will help us use the right dose. Amphotericin B is a great drug for killing mold, but it's also really good for killing multiple organs if you use it over a long period of time at high doses. So it can have nephrotoxicity, neurotoxicity, hepatotoxicity, and a rash in the skin. So if any of those things happen, or particularly if you're getting renal failure, which it can cause, you want to really consider changing the drug or pre-hydration before giving an amphotericin infusion can really help protect the kidneys from damage. Cyclosporin is another one that we use really commonly for protection against GVHD, and that can cause nephrotoxicity, neurotoxicity, hypertension, and liver enzyme derangement, amongst other issues. So if you're getting renal failure, even though the renal failure won't change the drug level, it's the drug level that might be causing the renal failure. So we would consider either reducing the dose or changing to alternative GVHD prophylaxis therapy for that reason.